Welcome to yet another session of Radio Finance. Today, my guest is Professor Dale Fisher, who is the Vice Chair of the Global Outbreak Alert and Response Network, an agency at the World Health Organization, who was also a member of the WHO China joint mission to China, to Wuhan, and various cities in China, where they studied how China was responding to the COVID-19 virus. He's worked on a number of previous pandemics, SARS and H1N1, I think, and also Ebola and so on. And so a global expert in infectious disease. I did ask him if he was more of an epidemiologist or a statistician, and I think the answer that he will give would be very interesting to hear, because I think that as we think about the impact of the lockdowns taking place in many countries, it's more a numbers game rather than a virus game, if you were to argue it that way. Let me just go through a short presentation to bring us all up to scratch in terms of where we are right now. Okay. If we're all trying to get through that graph, the bell curve, China seems to have gone down the other side of the bell curve. Right now, worldwide, 1.3 million people are infected with the virus, 74,000 dead, 370,000 infected in the US alone, 10,000 dead, and so on. And there are other ways to look at this data. People per million in terms of population and affected or infected, you would find that countries like Switzerland, Spain, Italy has in excess of 3,000 per million people have infected in their respective countries. And China, where it all started, despite the large numbers, it has only about 58.3 million people affected, as a proportion of the total population. And it is in remission, as well as China has taken the reverse course of closing its borders because of fears that the virus will come back to hit it from returning Chinese and visitors from abroad. In terms of the approach taken by the different countries, there is mass testing, there's contact tracing as first lines of defense. Some countries have done mass testing a lot better than others and contact tracing, but it's not widespread in the way in which it's being applied, and that has shown to have had effects in countries that have not started earlier in the course, and therefore are seeing a surge in hit rates in terms of the number of people affected. Worldwide, more than 125 countries have imposed lockdowns and causing a lot of disruptions in business, work, livelihoods, and so on. And that is the purpose we are here to have this discussion with Professor Dale Fisher. Thank you very much for joining me here today. Straight into the first question, the whole idea of a lockdown playbook, as it were. Is it a statistical warfare, or is it an is it a virus warfare?
There's plenty of military analogies flying around, don't worry. Listen, a traditional outbreak response, whatever it is, whether it's cholera or Ebola or anything, a foodborne outbreak, it's find the cases, so early case detection, diagnose, isolate appropriately, find the contacts, track the contacts, and if they get disease, then you can isolate them quickly. And eventually, if you keep isolating the cases, you can shut down the virus because you're stopping it spreading to other people. Now, there is really no playbook which says lockdown.
Is that a Chinese invention, by the way, the idea of a lockdown?
I think China maybe did invent it in January. And this is telling people, go home, no work, essential services, but no work, no fun, no entertainment. You go to your house, you only come out if you absolutely have to. Now this shifts the transmission into households. So you get the household clusters, but eventually it burns itself out. Now, if you do that for maybe 4 to 6 weeks, then actually you will bring down transmission.
You say bring down transmissions, or is it slow down transmissions? Is it inevitable that this particular strain of virus is something that is going to be endemic rather than pandemic?
Yes, it'll end up endemic. So the end game really is that now the best countries can do is try and contain it to as low as possible, because we know if you don't contain it, it kills tens of thousands of people and overwhelms your health systems and things like that. So we have to do whatever we can to contain it.
So then the question with the lockdown period is, are we talking let's try 1 month, and then if it is still proliferating very quickly, and then we try 3 months, and if it's still proliferating, what are we seeing now for the countries that had lockdown for sufficiently long period?
Okay. So there are 3 things can happen during a lockdown. 1 is you'll reduce transmission. 2 is when there's less cases, the hospital system can recover. So instead of having full beds and all your ventilators taken up, that will clear out. Either people will get better or they'll die. But so the first one will take, the transmissions should take 4 to 6 weeks. The second one is the hospital recovery, and that's going to probably take a little bit longer. Maybe 8, 10, 12 weeks. But the hardest one for many countries will be, how do you reopen, and how do you reopen with, you need to have all those traditional things in place. So how much contact tracing you can do, what sort of quarantine facilities you've got, what sort of laws you've got in place to, public health laws do you have in place to make sure these are brought in. And this will actually take longer. Somewhere like US and Europe, they don't have these systems in place like China, Singapore, Korea, Taiwan, Hong Kong. We all have these systems in place. So this is why a lockdown in Singapore really could be 4 weeks. My gut feeling is, if it's going well, they'll say, let's have another 4 weeks. But they may be able to start undoing the screws quite quickly, because our hospital system is not overwhelmed and our systems are in place.
Here's the question that we need to tag to the approach, which is, at what cost? You just said that if Singapore finds that a 1 month lockdown is working, then another 1 month for precaution's sake will be good. But that's 2 months, and the impact on the economy will be something that is a price that not many countries would want to pay. The question is that, for how long, at what price, and for what effectiveness?
I still think the mainstay is what I said about case detection, testing, isolating, quarantining, all that stuff.
Yeah.
But the only, so after that, the only dial you've got is the social limitations, right? And you can ramp those up and tell everyone, you're locked in your house and you can come out once a week to go shopping. That could be the extreme. Or you could say, we're just going to close the nightclubs and the discos and the movie theaters, because they're quite risky. And in between is where you've got your dial. China dialed it right up to the top. You might find in Europe and the States that everything's a little bit different depending on what stage of what they regard as essential, and also what the community can tolerate. Let me talk about that second month. I think agility is very important in a government. So to be able to respond quickly to shut down or to tighten the screws is good. I don't believe that in a month the second month would be exactly the same. That they may tighten up or they might ease a few things off. But I think in Singapore, they're really very, very, I guess, tactical, if you like. And they might say, you know what, we can open up those businesses again, but we better keep those ones closed. I think there'll be tweaking along the way and that sort of agility.
Bringing back to the same point, right? Taking the lockdown playbook, what are the parameters that you have in place and what are the indicators that you have in place that you like to look at to see how it will play out? The rest of society doesn't have the rest of the year to be locked down. The idea is to reduce the mortality, and there are mechanisms by which infectious disease, can exist in society and be dealt with. So what are you looking at in terms of this particular COVID-19 lockdowns? When it works, what happens? When it doesn't work, what's the next thing that you need to do?
Yeah, so it's a question of how to come out of lockdown, and I think you can, but it's going to be easier for some countries than others. It won't be able to. I think it's a long time before we've got 50,000 people at a football match again. But I think by and large businesses and construction and things like that can get back. But there'll be some. I think there'll always be some limitations. But it needs to be supported by this capacity to isolate the positive cases and things like that, which most countries still don't even have.
I seem to get from this that the professionals in infectious disease are proposing lockdowns or anything that reduces mobility in order to be able to slow down the process of infection. But that may not well be the final answer, as it were. We do not actually have a foolproof working model. Would it be that people in your profession should be saying that actually we don't know how this is going to play out, we're making it up as we go?
No. We know a lot. We know that if we don't try and contain it, then the death rate is really high. And we know if we don't do everything we can, then it's very infectious. So, and we know we can contain it with lockdown, but obviously we don't want a lockdown. And that's why Singapore has tried not to lock down. And I do believe in the next month or two, things will come easy again.
I have a question here from one of the viewers here. Given that most of Europe has a highly diffused infections, doesn't contact tracing have to start with testing the entire population? In other words, a lockdown timetable means testing everybody or everyone as much as possible.
You see that it wouldn't really help because you can be negative today and positive tomorrow. So it'd only give you a snapshot of that particular point in time. Once you've lost control like they have in Europe, then it's really just everyone stay in your house. If you've got severe disease, come out and we'll look after you. But otherwise, just let it burn out in the houses.
Right. So what do we know about the antibodies, for example, that if you get infected, are you therefore immune as a result that you actually build the antibodies? Do we know enough of that at the moment? But I'm using that to question your point that that you actually reduce the infection rate. But if it's going to be endemic, it means that all of us will eventually get infected. It's just not all at once.
No. So the end game is a vaccine. I would not be advocating for natural herd immunity. I think herd immunity will come, but it needs to come through a vaccine because there's just too much devastation if everyone has to get naturally infected. 60% of the world, you just do the maths in whatever country you live in, it's really millions of people need to get disease, which means, tens of thousands per day sort of thing. And that'll be the case for a year or more. So no, I think the end game is there's a vaccine, and that will cover most of the community, but vaccines aren't 100% effective anyway. So the disease won't go away, and not everyone will have the vaccine.
In the absence of a vaccine, the testing has to be perfected. And the testing has to be made cheaper, more available, and faster. And I think that some of that is coming through. When do you think widespread testing and easy testing will become universal?
So there's a few tests being developed. So the antibody tests are coming, but they're not going to be good for diagnosing disease. They'll be good for diagnosing recent or past disease. So if you want to know if you've been exposed in the last 3 months, you could have an antibody test. But to diagnose it now is a PCR test. And you're quite right, that's got about a 6-hour turnaround. I know they're trying for some antigen-based tests, which hopefully will be rapid and point of care.
Sorry, the number of questions coming on through. One straight out question, is herd immunity a misstep?
I don't think. So the only way herd immunity could work is if the antibody tests find massive asymptomatic transmission. If we find, if you need clinical disease to be antibody positive, then I suspect then herd immunity is not going to be a thing. We know a lot of children are going to be antibody positive because they're not getting, they don't get symptoms, and we know they're getting exposed and they've got asymptomatic disease. So there's going to be some asymptomatic spread like that. But if you think of it, if the US is 250 million, and let's say 250,000 have so far been infected, then that's like 0.1%, right? So to get to herd immunity, you need 60%. So if only the clinical cases are becoming immune, then you can see the devastation you need if you're going to get to herd immunity by natural exposure. Now, if we find that maybe 10 times, then it's maybe 10 times that number because of all this asymptomatic transmission, you're still only at 1%, and you've got to get to 60%. So the antibody studies are going to be important, but I honestly don't believe there's going to be so much transmission that natural herd immunity is a good thing. I think it's still going to come down to a vaccine.
How influential is the agency that you had, the Global Outbreak Alert and Response Network, the network itself? How influential is it in countries like the UK, which seem to favor, the herd immunity type of an approach? You seem to suggest that herd immunity is not the way to go. And some of the Western countries are discovering that as the numbers come in, as it were. And yet, testing is not something that they're even able to do, extensively. And those who are against testing are even complaining the fact that you need to do multiple testing in order to, to actually know the numbers and how they're working out. So, is that a coordinated global response, or are different countries, taking their own responses and hoping that, a certain methodology would evolve from there?
So it's a good question. Normally, when there's an outbreak, our, GOARN, the Global Outbreak Alert Response Network, will be called on by our member states saying we've got all this yellow fever, we've got all this cholera, or we've got all this Ebola or whatever. And we can help support the country's response. We can send in some experts during the West African outbreak. We sent in about 11 or 1,200 people during the course of that outbreak. But of course, it's much more difficult dealing with a total pandemic because, well, for instance, I can't go and help in Africa now because I'm required here. So anyone that works for a national body has to really do their work at home. The other thing is the narrative was stolen quite early by politicians, I'm afraid to say. And I think you can think of all the countries, and these are not outbreak specialists, and often the chief medical officer are not ID infectious disease people.
You were in that team that visited Wuhan, the WHO team that visited Wuhan. What did you see there? What were they learning as the pandemic was evolving? What lessons did you take out from the Wuhan meetings that you attended?
I was on the mission, but only 3 of the members went to Wuhan. I went to Beijing and Chengdu and then Guangzhou, and we all met up at the end. So we started together and then we ended up together to write the report and share all our ideas. I don't think there's anything in that report that has been shown to be wrong. We knew this could be devastating because we saw the devastation in China. And there is actually a sentence in there that says, this can have massive health, social and economic impact. And we don't think the world has the capacity or the mindset to deal with it. So we had a very negative approach, and sadly we're being found to be correct.
Well, in the report, you said that the so-called crude fertility rate was 17% when the pandemic started, or rather when the whole thing started building up, and then it was brought down to 0.7%. What was the cause of that large mortality rate, and what happened that brought it down very quickly to a manageable number?
So when all you're doing is identifying the very sick people and the dying people, and you're not recognizing all the mild disease, then your denominator is underestimated. So that's the first thing. The other thing is when your hospital is overwhelmed, you can't look after people properly. And you can see, so you see now Italy's running at 10% or 11%, but that's largely because they've stopped testing the mild ones, but the hospital's overwhelmed and they're just telling people, sorry, we're out of ventilators, good luck with your oxygen mask. So the case fatality rate should be less than 1% when things are going well, but when you get overwhelmed, and you can see how easily that can happen, the death rate goes up.
Hasn't the WHO also been on a learning curve? At first, the messages that you've been putting out was, you don't really need to wear a mask, and if you need to wear it, you have to wear it correctly. And then now it's wear it if you can. The second is how contagious is disease, and that asymptomatic people can also spread it just as virally.
Firstly, of course, we're learning. The pre-symptomatic, so that's shedding virus before you actually have symptoms, that's been proven to be true recently. I'm not sure asymptomatic spread, but presumably it's possible. There are people that never get symptoms. The whole mask thing is quite contentious. In science, we don't believe in general, most of us, in public wearing of masks. I would much rather say distance or don't go out. So if you're keeping your distance and if you're washing your hands so that anything you touch doesn't get into your mouth, then that's safe. We think it can be managed with, people that are sick wearing a mask, healthcare workers wearing a mask, or if you're looking after someone sick, wear a mask because you've got that continuous close contact. But, none of us believe that this is floating through the air.
Let me go into one area which probably has never been asked before, but the whole governance model of the relationship between the foundations, the pharmaceuticals, and the agencies such as yours, the Global Outbreak Alert and Response Network. Who funds your agency? Is it just countries, or is it also large businesses?
No, it wouldn't be businesses. It's donors. So these are sometimes countries, sometimes organizations. WHO, which gets its money from the same sources. So no, but there's no sort of private, for-profit business involved.
One of the criticisms of donors, foundations like the Bill Gates Foundation is that how much of that is donation and how much of that is investment in pharmaceuticals. And that relationship, I think there's another dimension of criticism coming through, saying that there is a kind of a covert, agenda, to get the whole world vaccinated because that's good for big pharmaceuticals and so on. Where are you on that conversation?
Yeah, I'd say it doesn't impact us at all. We wouldn't take money from pharmaceutical interests. WHO has to be very squeaky clean on all this, obviously.
Just coming back on numbers again, we don't have a global uniform, data that we're looking at. When the US says that, it's got, so many dead, that's different from what the Italians say and what the Chinese say. And where you have countries that are promoting herd immunity, you don't even know what the numbers are in the country. So it's very difficult to come up with a well understood global response, as it were.
My colleagues and I that are in the outbreak sort of business every day all believe that herd immunity is just madness. The governments that have gone for that, I've spoken to science, outbreak epidemiology people, and they have said, I cannot convince my government that this is, mad. And I think England actually did backflip within a couple of days when they said herd immunity. But I think the relationship between the leaders and the experts is pretty wanting in most countries. I don't see CDC standing next to Trump at the moment. So clearly, the advice is not being heeded, so they've been moved on.
Which countries do you think have got the equivalent of CDCs that work as they should? And what should be in place for CDCs to be able to function, as they should?
Yeah, I mean, it's a good question. It's across the world, it's very messy. Who's in charge? Is it the national level, or is it the state and provincial level? And I think most countries haven't really got it sorted out. I know in Australia there's a lot of tensions, and some people have got powers for some things, and then the national have got power for something else. But then I've heard in Germany they think it was this devolution of public health response to the states, which was part of the strength, because those people really had good relationships with their community. What it should be, I don't think there's one model suits all. I think it depends on your system of politics, and
okay.
It's different in Middle East and as well.
Would it make a big difference if a country like the US took the leadership, formed used your agency or some platform and created a coordinated approach towards the lockdown, so that we can see where the movements are? Different countries will have to have different responses depending on where they are in the transmission cycle. There should be leadership much stronger than what you have right now.
Every country's got its own sovereign right. So WHO can't go to UK or somewhere and say you're doing this wrong, or go to Iran or China or anywhere. The WHO's got no power. Every member state of the world has its own authority to do it. We make recommendations and we offer help and we share experiences, but we can't do it. You know, even the experts within the country often have problems getting the message through to the leaders.
The sense I get is that we're all learning as we go along, and the data is not uniform, the responses are not uniform, the disciplines are not uniform. It does look like that there should be a more coordinated global response and authority, and the people who have that authority are not asserting them.
The only people with authority are the leaders of every sovereign state. There's no one else, there's no world body with authority. They might have influence, but that's the most. And a coordinated global response, no, this is different in every city, in every country. Everyone's got a different population density, a different population number, a different mindset, you know, as to what they're prepared to take. What's the trust in government? If you don't have trust in your government, then the people also aren't going to respond very well. So it's chaotic. I don't take that away from what you say, but there are many reasons that's chaotic, and there really is no one except the sovereign leaders that can say, this is what we're doing in our area.
It's been a revealing conversation. I think it's more in the dynamics of our conversation rather than any one answer. You did let through just now that if the lockdown in Singapore works for 1 month, it will be a good idea to have it for a second month, which I think, coming from an infectious disease specialist, it's very interesting because it sort of reveals how you think about the effectiveness of these lockdowns and the goals that you want to meet. At the same time, you did say that the real goal that you're looking forward to is a final vaccine, which for a number of the pandemics that we've had recently, we've not had that solution. So, I think you have given us answers without realizing that you actually had. Thank you very much, Professor. And we hope that we can draw from you again as we navigate our way through this crisis.
Together. Yeah, okay. Nice to meet you. Bye.
Likewise. Thank you very much, Professor Dale Fisher. That's as much as we were able to cover in today's session. Please write your comments in the platform on which you will be watching this recording. We have Radio Finance is on SoundCloud as well as Podbean and Spotify and iPod, as well as our own website and Facebook and LinkedIn. So please go into any of these platforms and give us your feedback and join us again for future sessions where I will be talking to a wide range of different people in terms of how this virus evolves worldwide. Thank you.